Okay, so that is your slide of answer.
Got it.
So everybody, we've now moved on to spinal simplicity, and spinal simplicity is here to represent a posterior lateral arthrodesis. While they're getting everything ready, we have Katie here, who is wonderful. Katie comes to us from Michigan, and Katie likes to lift very large objects into her truck and out of her truck so that she can get to her doctor, like Dr. Giuseppe Paisi here. So we are so blessed to have her. She does all the marketing for the company. But Dr. Paisi is one of those people, as I was an early adapter of this company and this product, I really had a chance to start getting a lot of phone calls from reps from all over the country. And this rep from Florida, Josh, started calling me, telling me, hey, I need you to talk to one of our guys. And a lot of times you talk to somebody and they don't follow through or maybe don't get to a national lab or they're just kind of kicking the tires a little bit. This guy is the complete opposite of a tire kicker. The minute he started calling me, asking questions, he was ready to go. And it didn't stop. After that, he did his first couple cases. He got a couple tricks and things he wanted to talk about, and we've been talking ever since. And now he's one of the key opinion leaders for the company. So full transition from a person not even doing the procedure to a KOL that Katie's glad to put in front of everybody. So welcome, and we're so glad to have you here, brother.
Thank you. Thank you very much. And I'm excited to present this to you guys. Gents and ladies, to understand the concept of when to apply this, how to do this, and seeing how great this is going to be for your patient base. I think it's going to be a vital, important part of your repertoire as you get trained and get educated and get out there and start practicing. I think you're going to love this because the technique is foolproof. It is excellent, and you're going to see the outcomes of your patients, and it's going to propel you to want to keep doing this because you can provide an end game for your patients, and you'll see how in just a minute. So I'm going to go to the first slide here, and
Who's that good-looking guy? That was how many years ago was that, and how much Botox ago?
Yeah, well, you know, the Florida sun does its thing. So, okay, so let's talk about prevalence. So when are you going to utilize this procedure? So first thing I want you to identify with is that lumbar spinal stenosis, which by the way is why we would, one of the reasons why we would use this. 1.4 million new cases every single year, every year. So and then the next slide there is, at any one given time, 5 to 45 million people are simultaneously diagnosed with this across the United States. So more than an abundant amount of people are going to need this particular device, the Minuteman implant. So the next one here, 1.5 million epidurals given every single year. So you know this is being treated. It's being treated, you know, spinal stenosis and degenerative disc disease. These people are being treated with a lot of epidurals, which is right in your wheelhouse as a pain physician, right in your alley. So you're going to be seeing these kind of patients. Now, of those people that are being seen, and of the people that are getting epidurals, only a little bit over 175,000 are actually getting decompressed. In other words, they're having surgery afterwards. So you can see the vast discrepancy between how many millions of people are out there suffering and how many people are getting some sort of surgical intervention to help them. So a huge, huge amount of people that we can utilize or that we can deliver this to and provide them with an end result for them to take care of their back pain. So right here on the table, you can see that the slide of spinal stenosis. You can see the MRI. You can identify with that. Now, indications for use, we kind of touched on this a little bit, and I'm going to give you a little more information. Spinal stenosis. A lot of people over the age of 60 are going to be walking around with some form of spinal stenosis, whether it be mild, whether it be moderate or severe. So you're going to see this. They're going to start walking into your office. They're a little bit bent over. They get relief when they sit down. It's worse when they stand up. They can only go a block, and all of a sudden they have to sit back down. So you're going to hear this over and over and over again in your office. And you're going to be able to identify with these. You're going to have something for them. So degenerative disc disease. I mean, this is what we treat all day long. We see this in our office. We see this with our patients. It is part of the pain profile that you're going to see when your patients enter into the office. So they're going to be complaining of this. It's hard to have degenerative disc disease without some kind of spinal stenosis being involved as well. Facet arthrosis. The last one, spondylolisthesis. These are the three key diagnoses you're going to identify with people that are qualified to have this procedure done. So any of these three procedures are going to be the main target for implementing the Minuteman device, and it's going to encompass approximately a large percent of your population, and I'll get to that slide in a second. Over here we have a little flow chart of when am I going to use this. You're going to be seeing these patients every single day, as I said. You're going to be giving them epidurals. When would be a good time to implement this? Well, you can have a flow chart, a protocol. Me particularly, I don't know about you guys, but I like to give an epidural or two to, number one, identify the location of their problem. We want to make sure that we're in the right spot if you're going to do this little implant. So usually if we give an epidural and they get great relief, but it just doesn't last very long, then you're going to want to consider that you're in the right spot. And that is another indication of, okay, how long does the epidural last? Well, if it only lasts a couple weeks, if it only lasts even a month or so, and the patient doesn't want to keep getting epidural after epidural and it's limited, now again, you're in the right spot because you usually get pretty good relief, and then you continue to have pain because it doesn't last very long, that's going to be a great patient to implement this device. And so you can look through the flow chart there. If they're getting relief, then obviously you don't have to implement this. You can send them to therapy. But if you keep ending up in a position where you're only doing minimal benefit or it's only lasting so long, you need to consider the Minuteman device. All right, so a very important slide here. I love this middle slide. That is called facet inflammation. And if you look at the MRI on this slide, you can see you have probably 3 to 4 millimeters of inflammation within the facet joints. That's not supposed to be there. That is typically identified when you have somebody who has a lot of instability at that joint. There's a lot of pain typically at that joint, and they're going to complain of back pain, and it's going to be a wonderful patient to provide relief for. You might give facet blocks to this patient, and they might get great relief, but then it just doesn't last very long. That is another indication there, that middle slide.
Let me highlight what Giuseppe's saying here. When you look at a patient and you go, there may just be maybe a tight grade, just a little bit of grade 1 slip. It may be a little more than that. When you see a little slip, but you definitely see ligamentum flavum hypertrophy, and you see a facet effusion, you've got micromotion. There's
Absolutely.
really no other two ways about it. So those are the people who start to think about.
And those are the patients where what Dr. Paese said, Giuseppe said, was you do the shots and they get better. They do,
Yeah.
but it's going to come back because there's motion.
Yep.
So you're going to build that inflammation back up. Everything's going to start building back up. You can't keep it away. What I tell my patients is the only way to keep this away is to stabilize.
Stabilize it. Yep.
Absolutely. So you've got a little bit of instability at a joint, and you have it continuously aggravating. So you can try and keep up with it, but eventually the pain is going to continue to come back, and you need to have an end game for your patients, and this is a perfect time to implement this device. Next slide here. Again, these are the 3 diagnoses that I wanted to emphasize. You've got degenerative disc disease, you have spondylolisthesis, and now you have spinal stenosis. Those 3 diagnoses in and of themselves are going to constitute over 50% of the people walking into your office with back pain. So you are going to have a large amount of people walking into your office, every other one, that could potentially be a candidate for this device. Okay, so let's get on to the actual procedure, and you can identify how to put this thing in.
While you're doing that, Dr. Giuseppe, one of the things that's great about this company is that they are constantly improving. And what I mean by that is literally every minute of every day and every night while sleeping, Todd Mosley, CEO, is thinking, how can I make this more user-friendly? How can I make better results for my patients, for my doctors? And so, Katie, why don't you tell us a little bit about the G5 and some of the improvements on the G5 so that everybody understands that even just really recently, there became a really nice additional tool for us to use.
Yeah, absolutely. So one of the things is it is now one piece. So that's important. We used to have a removable tail. At the end of the procedure, we just had to make sure that that tail was off in the inserter, and now it's one piece and we don't have to worry about those transitions. Full control over the implant. So our wings are able to open, close. If we don't like our position, the way the implant looks, you can close it back up, back it back out, and start over. It is all HA coated. So HA is a material that helps promote a fusion. So now it's not just the body that's HA coated, the wings, the back disc, everything's coated in that HA to kind of help and speed up that process of creating a fusion.
Awesome. Yeah.
So 60 degrees is the last big one, which makes it stronger. This is a stronger implant now that the wing's only open to 60 degrees, just from a biomechanical standpoint versus the 90 degrees in the G3R. So,
No, those are great points. We just want.
I think it's perfect. It's coming from the brains of an orthopedic surgeon, right? And we've talked about before already, but I want to bring it up again, that there's a lot going on between orthopedic surgeons, neurosurgeons, and interventional spine docs. And
Yep.
we're coming together. I think people are trying to say we're pulling apart.
No.
We're coming together. We're trying to help these patients in the ways we can. And what this device does is promotes a fusion much less invasive than the conventional way of promoting a fusion. And that's what we're trying to do for these patients. Less invasive, less downtime. I'm sure we'll talk about that as we go
Absolutely.
through. But it still gives you that nice, hard, solid fusion to fix that joint without all that open, extravasation that we have to do with traditional fusion.
So instead of just palliating pain, we're actually changing anatomy.
Yeah.
We're actually moving some of these spondies back into anatomical position and then fusing them. So it's a different mindset, Dr. P, that we have to had in the past. And so there's a little bit more preparation that goes into this than just a standard injection or procedure you're doing, right?
Oh, absolutely, right. But you know what? It's all within our wheelhouse. And once you get comfortable with the needle, there's no better physicians out there aiming with a needle, using fluoroscopy than interventional pain and pain medicine physicians. So you're going to be very comfortable with this. I want to direct your attention to the fluoroscopy here. The first thing you're going to do is you're going to line up your patient. I'm choosing L34 here at this particular model, and I'm dropping a 22 gauge, 3.5 inch needle right in between the spinous processes, and I've already kind of have this set up. I've got my Steinman pin in place here, and I have my first dilator in here. Now, essentially what I'm going to do, I want to quickly go to a lateral. I just want to show the people out there exactly what we're identifying with, because this is a really interesting technique, and we're approaching from a lateral position. When you approach from a lateral position, it's very safe. And there's hardly any blood loss at all when we do this procedure. We anesthetize with 1% lidocaine, maybe 0.25% with epinephrine. You're going to lose less than 5 cc's of blood throughout this entire procedure because of the way we anesthetize, the way we enter in. We're not dissecting and cutting through, we're dilating. Dilating is a huge difference between how normal surgery is performed and the way we're doing it here. So I've got this Steinman pin in place. Go ahead, let me see what we got here.
So we talked about a possibility of having a slip as having an interlisthesis. One of the things that helps stabilize a interlisthesis is the supraspinous ligament, which goes over the top of each of the spinous processes. And why that's important to not cut through that is because a lot of these patients that are on our top indication list are people that have a slip already. And so what we want to be able to do is we want to be able to get to the space anteriorly without having to cut through the back and go through the multifidus muscles and all the other muscles, that sort. See if we can get a good lateral. Sometimes it's kind of hard.
There we go. Okay.
Yep.
All right. So I'm not sure. What we can look at there is that we're trying to get in between the spinous processes. And if you can identify the spinous process, you can see that my Steinman pin is going right at the anterior 1/3 portion of the interspinous space. Yep. All right? Yep. We are in the interspinous space. I don't want to be too far posterior in between the spinous processes. I want to be in the anterior 1/3. That is going to guarantee me a good position, stable area. This is a very robust piece of titanium, and it will hold that segment in place very nicely. I don't want to be too far back because I don't want to create any weakness at the spinous process. So let's go ahead and go back AP for me. Oh, also, before we go.
There's more?
There's more.
Okay.
Don't ask how much. There's more. Let me have a Steinman pin there, please. Stay just right on the other side there, just another. What I want to show you is that when you're lining this up, we have a safe zone here. Okay, a safe zone is going to tell me where I'm drawing my lines, and you can see that I want to be like right there. I am at the superior portion of the facet joint, or the posterior aspect of the facet or the posterior lamina. I draw a safety line there. So when I'm setting my patient up, I'm going to draw a line right there on the skin, and I know that I want to stay above that spot so that I don't go too deep and I'm not hitting anything vital. So as long as I stay above that, incredibly safe procedure, and you can be confident that you're going to help your patient without creating more irritation.
I think that's one of the questions we get whenever someone sees spinal simplicity but hasn't done the procedure yet. They're worried that it's going to be a little... you're a little too destructive, or we're going to get in the way. I've heard people say, oh, what if you hit the kidney?
Yeah.
I think Doug Beal says it best. You have a better chance of hitting the brain than you do the kidney.
That's right.
If you know where you're going. This is what MedEd Combine's all about. It's to understand the procedures are safe, understand this is in our wheelhouse, and really look at what this is, and then take it to the next step. Reach out to the company, reach out to Katie, and get trained. So let's show them how to do it.
Absolutely. Okay.
Perfect.
So I've already got a Steinman pin in place, and now I have the first dilator over. And remember, dilation is different than cutting. So I'm opening up and I'm squeezing this into place. And every time I get that into place, I take a picture, and you can see.
Are you
Straighten up that
too
patient.
strong?
Sorry.
Straighten up that
He
patient.
usually moves his pages around just like that.
He's been working out.
They would normally
and
strap
so-
down a little bit better.
So that's one. Here's the third dilator.
I'll give you
And you
some
can see
traction,
each
brother.
one sequentially opens up the space a little bit better.
We usually do have the.
And I can
the-
push
You got an
that.
assistant for that,
It's
yeah.
like help you out.
Yeah. I go to all his cases and hold the cadaver for him.
All right, and you can see, as long as I'm within a centimeter of the lateral aspect of that spinous process, I'm in good position. I want to be over top that facet joint. So I'm lining all these up. This is going to be my very first sleeve. So once I get to this first black sleeve, the first 1, 2, 3 devices can actually fit through this.
Yep.
What percentage would you say fit through that device?
Well, now with the G5, everything but that
Really large.
really 16 goes through that first working sleeve. So
about
I would
95% of
say
patients?
90, yeah.
95.
95%
Yeah.
of patients.
This is huge because it can
yeah.
be the difference between somebody being able to almost do this case with just local versus having to be under general anesthesia.
So remember-
less is more, right?
Exactly.
Yep.
We are
Yeah.
making a very small footprint on this patient because of this. All right. So my incision is probably 2 centimeters, lateral aspect going in. Now I'm in position. Now that I've got all this in, I'm pulling, yes, with the Katie tool.
Yes, the
I'm
Katie
pulling
tool.
these things out.
So there's these little stair-stepped adapters, and you use those. You can pull them out one by one, not to lose our Simon pin.
So now I've got these out. I've taken them out. My sleeve's in place. Okay. Everything is good. Now we're going to drill.
So what's the? So there
So
is a
this-
step where you could rasp if you had to, right?
Yes,
But
yes.
we
Yes.
rarely, 5% of the time, need to do that, right? But that's the nice thing I like about this kit is they thought of everything. They can
Right.
get you just like if you're in the OR doing surgery.
Yep.
You can get in and out of any problem you have to with all the techniques they have. Because some of the people say, you know, well.
Sorry, it's
Can you get
stuff
around?
that we're
It's
using
easy to do on the easy patients,
bilateral.
right?
too
It's
much
easy to do on
Clyde
easy
in
patients, but
Yep.
can you get around a tough patient, tough anatomy, scoliosis? You've probably done everything you could see, right?
I've seen a lot.
And they have all the tools to do that.
All right.
This is true.
What you can see here is I have this dilator. This is a coring drill, and as it goes through the interspinous space, it is actually decorticating a little bit of the inferior portion of the spinous process and the superior portion of the spinous process, and you're creating a nice area for this fusion to occur. All right, so I'm going to open it up, and I'm going to go forward. Thank you. And I want you to look right there at the holes. You can see the holes there on this slide here on the fluoroscopy. That first hole represents an 8mm device. The second hole is a 10mm device. Then we got a 12 and a 14 and a 16. So it depends on where you're at as you're going through and you're feeling the tension and you're starting to sense that tightness, that separation. You know that you don't have to go any further. And once you get to that point, you say, okay, oh, we're at a 10. Or so if I get to that second one there, you're going to see.
I think what he's saying is super important. Sizing is very important, guys and gals. And so one of the things that he's going by is what he feels by how tight it is that he twists it. But we're also looking at our picture, so we're trying to see if our mind and our hands are talking. And we should see that we're touching either side of the spinous
You
processes,
should.
right? So when you're doing this and you see it's getting pretty close to the touching and it's getting tight, that's probably the right size.
Absolutely. So I would say in this particular patient, we're going to put a 10 in. 10mm device. That should provide enough decompression. As I'm putting that between the spinous processes, I'm creating space. I've taken two bones and I've stretched them apart. We're creating space in the IVF. We're creating space in the spinal canal. So you're actually making room, particularly if you have, and you're decompressing the disc. So all of this is occurring just by opening up that little wedge space there. And then we can take this out now that we've made that hole.
And this is
You guys can
this
see
is
over
the,
here,
This
this
is the
is the
coolest
G5.
tool around.
Yeah, so I'm just loading based on what he did, and then he'll mess around with one more thing, but we're loading this on the back table, making sure that the wings can open and close. Really gentle with loading that back on.
That's perfect.
That helps open that space.
Yeah, this is my Pathfinder. I kind of put this in, go across to the other side and pull back through. Make sure that I've got good space on the contralateral side that I entered into.
And to help, so you know where the wings will open up. correct?
Absolutely. All right, this is our lightsaber.
And we talked about the HA coating that is now along this entire implant, but in this area here, this window in here, you can see there's a bone graft window. So this fills up with bone graft, just like any other product out there from other spine models.
Yes.
And that's what it really encourages the fusion
So-
along with the HA.
Hydroxyapatite crystals on the outside, bone graft on the inside, and looped around there. This thing is going to take hold in a matter of months. So once I get it into place, you can see my device. You can see I'm in that spot. I start rotating just like a screwdriver, and I'm putting it in. Sometimes I do it under live fluoroscopy so I can see it. I want to advance it until I get beyond the wings to make sure that I have a uninhibited opening of those wings, and you'll understand that when we get through to the other side. So now I can see that my wings are practically, there's a bit of a
There we go.
bit of a lucency there, and you can see once, that's the edge of my wingspan. So maybe another turn or
Couple
two,
turns, yeah.
so I can get
Couple
through there a little bit more.
There you go.
There we go.
There you go.
All right, so now I'm good, right there. Now, I'm gonna open this up live. I want you to pay attention to the fluoroscopy and watch these wings open, okay? So from here, look at that. That's exactly how it's gonna happen in the patient, all right? Now that I've got them open, I wanna bring it back in and clamp down around the spinous processes, and I do that by rotating this button up here. Button.
Knob.
Knob too.
We call them knobs in
Knob,
Texas.
knob.
I don't know what you call them in Florida.
All right, and now I start rotating this, and again, I can do this under fluoroscopy, and I'm gonna hold this in a position because I like the wings to be perpendicular to the spine. And I can start bringing this back. And as I do this, it's gonna cinch in, and it's going to,
You see how on the right of your screen you see the spike plate coming up against
There we
the
go.
spinous process?
Yeah.
Then it will start to come together as a threaded body.
now you can see from the AP projection here, I'm up against the spinous
be getting pretty
processes,
tight now.
up, and I'm also against the lateral and contralateral, ipsilateral contralateral spinous process, and I can feel it getting tight, so everything matches. What I'm feeling here matches what I'm seeing on my x-ray, and it is a good fit, and I'm done. Once I get to this point, I'm locked into place, it's nice and tight, and now I just take my back knob and I deploy by unloosening this counterclockwise. Once I get that, I'm applying a little bit of pressure, and it pops off,
Love that
and
sound.
it's in.
Easily impressions like Anthony.
I know.
Yeah.
Then we look at it, you can see it's in place here. It looks like it's in great position. I pull this out, and when I pull it out, all the skin just kind of folds right back down around it. Again, very little bleeding, and I'll put maybe some 2O Vicryl or sutures on the inside, maybe some Close-X tape or Durabond on the outside. And that's it. That's pretty much the entry. It takes about, by the time you get everything lined up, about 20 to 25 minutes once you get really good at it. Can be even up to a half an hour, but it's a pretty decent procedure, minimally invasive. You're in and out, the patient's in and out the same day, and trust me, the pain that they're having is resolved to the point to where any minimal discomfort they have from the surgical procedure is easily compensated for, and usually within a week or so it subsides.
That's great.
That was
Dr.
very
Paisley.
good.
Yeah, no, that's an excellent summary. Katie, thank you for coming. Dr. Paisley, thank you for coming. And
guys
you
for
guys,
having
if you
us.
need to get in touch with Katie's the marketing person, but there's reps all over the country and there's labs every month. If somebody wants to get trained, reach out. And this is definitely something you want to add to your repertoire of pain management.
Absolutely.
Awesome job, guys.
Awesome.
Thank you very much, guys.
Great.
Awesome. That's the first time I've seen the new G5, and that's pretty
G5.
Try to
slick.
keep things away from you as long as we can.
I know. They keep it in the dark from me. Thank you very much,
All right.
guys.